Good morning, good afternoon, and good night, wherever you're watching us. It is an honor for me to share with you again one of my cases. I am Dr. Mahad, doing residence training program in China. Now I'm my last year, third year. Today I will share with you the Fluoroless flexible ureteroscopy for left kidney. We perform this for patient male, 20 years old male, which is having impacted upper ureteral stone, and we will use disposable flexible scope to treat this stone. The laser we are using is 100 watt luminous laser, holmium laser. So the first step of surgery will be rigid ureteroscopy examination. Now we come into the bladder and see the ureteral orifice. The ureteral orifice is not tight as we think for this patient. Now we put hydrophilic guide wire. So the technique of entering the orifice is just little bit rotate the scope, and when you come in, take your hand down so the tip of the scope can go up, and same time negotiate with the ureter. The vision is not good sometimes because there is a debris and pus coming out, because I close the inlet water and then open it, the outlet, to control the pressure. Now we reach the stone impacted in upper ureter. So we try to push, it's not pushing, it's not going easily, and then we make sure that the guide wire is gone to the kidney and then come back. I want to mention here the importance when you are coming back the guide wire. You don't need to push in guide wire. You just fix the guide wire. Look, my right hand, I am not pushing the guide wire. I'm just fixing the guide wire and taking the scope back. Why we do like this? Because we are doing fluoroless access sheath insertion. So we don't want any kinking in the wire. If you push the wire in, so the guide wire head will come back to the ureter and there will be kinking, and it's difficult to put the access sheath. Now is how to put the ureteral access sheath fluorolessly. It's Boston Scientific 12-14-46 centimeter access sheath. There you will feel three different resistances. Resistance number 1 in the ureteral orifice, and then now move the guide wire. No kinking, is a smooth guide wire. Now go on. If there is kinking and guide wire is not smooth, don't push it. Now we reach the second resistance, which is iliac resistance, and then move the guide wire again. And now before I reach the UBJ resistance, I feel another resistance. So the guide wire was good, but the scope is not going. It means I reached the impacted ureteral stone. So you don't need to overpush the sheath, so you may perforate. So this is overall examination for fluoroless insertion of access sheath. You just need to make sure there is no kinking in the guide wire, and then your tactical feedback will feel that the access sheath is going easily. The flexible scope we are using today is 8 French hook disposable scope. This is a digital scope and it is disposable, but you can reuse and re-sterilize it using low temperature hydrogen peroxide steam sterilization, STERAD. In our department, per scope we use it 25 to 30 times average, and per scope it's I think $1,000 per scope. It's good vision scope. So let's come back to our case. My teacher now is doing examination of the kidney and ureter. We reach the stone. You see the stone is direction of the stone is in impacted version. Now we push the water and push same time the stone. So stone directly go to upper bowl of kidney. Why? Because we make the patient head low and legs up. So the gravity will take the stone to upper bowl. So if you don't do like this, you may get your stone accidentally go to lower bowl, and it's difficult to deal with it. After examination of kidney, different part of kidney, my teacher invited me to do this procedure, and it is 2 centimeter stone. We will use the luminous 100 watt holmium laser. The laser setting is 2.0 joule for energy and 10 hertz for frequency. Why? Because we want to use fragmentation technique and not dusting technique. We want to fragment the stone and basket it and never leave any fragments behind. Why we don't like doing dusting techniques? Because the dusting, you can't remove the dust out. That's why we always use the fragmentation technique. Later, if there is some remnants of stone, we will use popcorn technique. You will see later. So, technique of doing fragmentation starts number 1 on the laser setting. It is high energy and low frequency. Number 2, the surgical technique. You should prevent stone to retropulse it. So how you will prevent it? As you see now, I am pushing the stone against the wall of kidney. Press the stone against the wall and touch once only the pedal, laser pedal, only once. Yes, why we touch only once? Because if you touch a lot of on the pedal, you will make dust. You will make small fragments that you can't basket it. So we touch once, like did it like this. But if you touch continuously, like no, you don't need to do like this. If you do like this, there will be a dust. There will be a lot of dust, and you can't remove this dust out. So we don't want. So there may be later some recurrence of a stone. It can be recurrent. This stone is not hard. It is calcium oxalate dihydrate, as you see, and we wanna make equal fragments and basket them out. So I want to mention here the technique of using the flexible ureteroscopy. Whenever we use the flexible ureteroscopy, we need to get a good vision. So to get a good vision, you need to do a lot of movements in different direction. So to get this thing, we have been trained on technique of using the fingers on the scope, so you don't need to use your palms. My teacher never allowed me to use my palms. Every time we use the fingers on the scope, and we can easily rotate the scope. Why we don't use the palms? So if you hold the scope with your palms, you can't move easily. So that's why we use the fingers. It is like the car steering wheel mechanism. When you drive a car, you don't need to hold the wheel, steering wheel on your palms. You must use the fingers because to move easily. My teacher now tell me that which stone is bigger that will not come out, and to target that stone and fragment it. Now look carefully the accessory head which holds the laser fiber and water flashing. It is been packed and it's been touched every time on patient leg, so I can't move easily. So I discovered later that's why you see my movement is very bad. Now I take it medially. So when you take medially, now I can rotate easily and I can target the stone easily. Here my laser go back to the scope, so I take it out again. You should be carefully that your laser, you must see the laser fiber, and don't ever press the pedal before you see the laser is outside. If you press while it's the laser fiber inside, you will damage the scope. Every time we should press the stone against the wall, you see, pressing against the wall, so less retropulsion and easier to fragment it and prevent to make any dust. Oh, now it is almost, we finished the fragmentation part, and now we will prepare to basket the stone. The basket we use is Dakota basket, so it is easier to grab the stone. Now look my right hand, how I am grabbing the basket. You don't need the basket to be far from your vision. Sometimes the stone will be locked on the ureter if there is tightness, but you must make sure that the stone, the basket, will not go far from your vision, so you can control the movement of the stone. This is number one. And left hand also have importance. You know, flexible ureteroscopy, when you basket the stone, the most difficult part is when you pull the stone, there will be some kinking in the ureter near the basket. So all the mucosa will come inside the access sheath. So it's not easier to come out. So what we'll do, you will see now, when I come out, look my left hand. I take the sheath little bit back. You see? When I take the sheath little bit back, it is easier to come out. You will straighten the ureter. But if you don't take the sheath little bit back, you can't straighten the ureter, and it's difficult to come out. So I'm controlling the first finger and second finger on the sheath, and my toe and third finger I'm controlling on the scope. You see, now my right hand I grab the basket. So feel the resistance. If there is a very very high resistance, don't over pull it. If you pull it very aggressively, you will avulse the ureter sometimes. So in experience, you will feel if there is a lot of resistance, don't pull it. Just release the stone and take the laser and refragment it and rebasket it. As you see now, the vision is not very good. Why? Because look my left hand of my teacher. He just push the water whenever we need a good vision. If we can see, he don't push the water. He use normal gravity water. Why we do like this? Because we wanna prevent any high intrarenal pressure. If intrapelvic pressure is very high, the patient may get urosepsis, and you know the number one complication of flexible ureteroscopy is urosepsis, fever, patient get infection. So we use the less water as much as we can. So here I want to mention that, as you see, I'm doing a lot of movements: pronation, supination, rotation, go right, go left. Because I'm doing this movement, it's a passive movement. It's been controlled. Look my right hand, how I grab the basket. I don't let the basket to be far from my vision. You know? Put the basket down again. So let's come back what I'm telling. Why we do a lot of movement when we are moving the scope. So there is a technique that my teacher told me. He said, be flexible when you are doing flexible ureteroscopy. Make your joints, every of your joints, all of them flexible. Don't rigid yourself. If you rigidate yourself, you can't move as you want. It means if the surgeons who's been trained on PCNL and rigid ureteroscopy for a long time, and then start training on the flexible ureteroscopy, you can discover their movements. Their movement is very rigid. They move like they are doing PCNL. So you will understand this surgeon is a PCNL surgeon. It's the same like when a long time laparoscopic surgeon, he suddenly start learning robotic surgery and then learn it. When he do a robot, you can understand that this surgeon is a laparoscopic surgeon because of his movement, the movement he's doing. So it's the same concept. You need to be flexed your joints. Now I discovered another problem. You see, the digital fiber, this tube was pressed against the rigid ureteroscopy on patient leg, so my movement was very restricted. Now I fixed that problem, so now I can move faster and do more free movements. Okay guys, enjoy the basketing part of the operation, and we will discuss later the other part of the procedure. As you see now, whenever the stone fragments become smaller and smaller, it is difficult to deal with them and grab them and basket them. It will be very difficult. That's why every time when we want to do fragmentation technique, we prohibit to use any dusting techniques or targeting the stone without pressing against the wall or pressing the barrel continuously. All this will cause to get the stone to make the stone dust small fragments that is difficult to grab them. This is upper ball of kidney. This fragment is a little bit big, so we take it out. Examination in different parts of kidney. Here's the upper ball of kidney, no bigger fragment. You know, upper ball have a medial and lateral, not have anterior posterior. This is the lateral, this is the medial, and now this is the middle ball. Middle ball sometimes one and sometimes two middle balls. Here there's two different. Also no fragments there. And now we will try to see the lower ball of kidney. You know, when you are using when you're using flexible ureteroscopy and basket is inside, to examine the lower ball is difficult. You know, you see, it's very difficult because we have basket inside of our scope, so I can't do a lot of movements here. But normally, mostly there is no fragments here. Later I will come back to examine again when I remove the basket. Now I am wanna do the popcorn technique of the laser, and the nurse change the setting of laser to 0.8 and 35 joule, 0.8 joule and 35 hertz. Now I take the scope back to the axis sheath, because whenever we put a laser on the scope, you must have your scope inside the axis sheath, so you will straighten the tip of the scope. If your tip is flexed or deflected while you are inside the lower ball and you put the laser fiber, you may break your laser fiber or damage the scope. Now waiting for the water come, and then go on. Move according to your vision. The popcorn technique is easy to do, just high frequency and low energy. Just put the laser fiber in the stone area and continuously press the button. The popcorn technique works on a closed area mostly. If the stone is in the renal pelvic, the popcorn technique will not work better. You need the stones inside the calyces, lower calyces or upper calyces. It's a closed calyces, and then you just put the fiber middle of the stones and press it. Put back the laser fiber. You see, continuously pressing the button like this, because it is a high frequency and low energy popcorn technique. Here the anterior part of the lateral part of the upper ball, there is another fragment. Every time you should rotate the scope so you can see in a different part of kidney. So as you see now, we make a fine dust. This fine dust will come out with the urine and will not make any renal colic pain. So this is the cause that we are using this popcorn technique. Here there is little bit a bigger fragment, and we try to treat this fragment. Now I come back to lower ball to examine it, if there is any remnant or any stones in lower ball. Take the laser fiber back, not to break the fibers, and now I enter lower ball. Now to move inside the lower ball is easier when you don't have a basket inside the scope. And now we finish our case and preparing to put DJ stent. We use 6 French DJ stent, which is lifetime is 6 months, and we put back hydrophilic guide wire on the sheath and make sure the guide wire reach the kidney on the scope, and then we take back the sheath and make sure that besides the access sheath there is no stones, and then I come out. You see, look my teacher's hand. He's not pushing the guide wire in. He just pull the sheath and stabilize the guide wire, so you will not make kinking the guide wire. So if you kink the guide wire, the DJ stent also will get kinked, and movement of and then the result will be bad. So now we finish the case and we put DJ stent. After 1 month we will remove the DJ stent, because this patient is having impacted ureteral stone. If the ureter is clean, no impacted stone, we put the DJ stent only for 2 weeks and remove the stent after 2 weeks in OBD. Okay, see you guys. I hope I will share with you another cases sooner. There will be a live surgical workshop, call it Power Surgery Forum, and my teachers will do cases and I will share with you. Thank you. See you again.
Okay, good job. Good job.
回去又能多挣好几十万。
你可以听那个。